Hi, everyone. Welcome back to Pulm Peeps. We're so excited to have our weekly time together and really excited to bring back another Fellows Case Files. We're recording in probably mid July. So lots of new excitement and energy around, I think, all residencies and all fellowships. How are you doing for?
Yeah, I'm doing great. That was a great time of year to be in the hospital. As you said, everybody's really excited. All the sort of core teaching topics I feel like come back up, which is always really fun. And actually a good reminder for me, I feel like to always brush up on certain things and certain physiologic concepts when the new residents and fellows are around. And yeah, very excited to be back with case files. We've done a bunch of journal club reviews recently and article reviews, but always love to tinkle our diagnostic brain and hear about a cool case from somewhere else in the country.
Totally. And we're also entering a fellowship application season. So 'tis the season to start. So we're really excited to be able to highlight a wonderful fellowship program today. And so excited, I'll go ahead and introduce our first guest. We have Dr. Jeremy Grossman. Jeremy completed his Medicine-Pediatrics residency at Stony Brook Medicine, where he also served as a chief resident. He is currently a second year fellow. So we were just saying in his second week as a second year fellow. So big congrats, Jeremy, who's currently at NYU. We've been waiting a while to get some NYU representation. So really excited for this episode today. And really excited to have you leading us through a fantastic case, Jeremy. Welcome to Plum Peeps.
Hey, Christina and Dave. I'm a big fan of the show. Thanks so much for having me.
Yeah, it's our pleasure. So, and along with Jeremy, we have Dr. Shari Brosnahan. Shari is an assistant professor of medicine and one of the assistant program directors for the NYU Langone Division of Pulmonary Critical Care and Sleep Medicine Fellowship. Shari completed her fellowship training at NYU in 2017 and has been on faculty since then. Her clinical and research interests are focused on pulmonary embolism and thrombosis and critically ill patients. It's great to have you on the podcast today.
Thanks so much. I'm so excited to be here.
Absolutely. It's a pleasure. The excitement is all on our end. Before we hop into the case, just our standard disclaimer. This is a reminder this podcast is for medical education, not for specific medical advice. The views we express today do not necessarily reflect the opinions or policies of our respective employers. We are going to hear about a case today. Some of the details may have been changed to protect the privacy of the patient, and everything we talk about will be HIPAA compliant. And so with that, we'll dive into the case. So Jeremy, it sounds like you had a interesting patient that you encountered. So maybe you could just tell us about how they initially presented.
Yeah, I definitely do, Dave. So today we have an 80-year-old male presenting with shortness of breath who was found to have a home oxygen saturation of 82% on room air, which corrected only to 86% on his home 4 liters of nasal cannula. For the months prior, he felt poorly with symptoms of dry cough, fatigue, and difficulty speaking, as well as ambulating due to shortness of breath at rest. He denied any recent fevers, sputum production, chest pain, or lower extremity swelling. I know this is a very brief history so far, but Christina, what is your problem, representation, and preliminary thoughts on the differential diagnosis?
Yeah, thanks, Jeremy. And really some short information, but I think you've already highlighted a couple of interesting points for us to consider. And just quickly reviewing, how do we develop a problem representation? We may have some new listeners today. As we said, it's July. So just thinking about it. So when we have a problem representation, right, it's different from the chief complaint. So we really want to look at three different things. We're going to be looking at who our host is. So this is going to include demographics. Is the patient immunocompromised or immunocompetent? Any risk factors, and any relevant travel or exposures. We also want to look at the tempo. So, is this acute, subacute, or chronic? And are the symptoms stable, progressing, or do they wax and wane? And then, thirdly, really want to look at the syndrome. So, what key signs and symptoms is a patient presenting with? So, Jeremy, based off what you said so far, how I put a problem representation together is saying that we have an 80-year-old presumed immunocompetent we have an 80-year-old presumed immunocompetent man with subacute dyspnea on exertion who's presenting with acute hypoxemia, dry cough, and fatigue with impaired functional status secondary to his symptoms. And when we're thinking of the differential, right, I think a lot of things to think about at this point, and always want to rule out anything acute that you can't miss versus some things that may seem a little bit more chronic in nature. So just as I'm trying to think about this, really thinking about lungs, heart, neuromuscular, and other buckets. So four big buckets. From a pulmonary standpoint, you mentioned that he's on home oxygen, and I'm sure we'll get more into the case and delve into that in a bit. But that just makes me think, what is his smoking history? Does he have any history from an airway perspective with any type of obstructive lung disease? He's an 80-year-old gentleman, so does he have potentially other parenchymal changes? Is he going to fall under an umbrella of interstitial lung disease that we should be considering? Thinking about vasculature as well, having any type of pulmonary hypertension secondary to either of these. We had a case files on pulmonary vein occlusion. So those are other things that we should be keeping in our minds. And any pleural disease. You mentioned some things that he hasn't had any recent infectious symptoms, but in someone who's had recent infectious symptoms and pneumonia, could he have now a secondary pleural effusion from that? So that's how I'm wrapping up the lungs. From a cardiac perspective, thinking of some broad categories, any ischemia or supply demand that could be presenting with dyspnea, so such as severe coronary artery disease, any recent MI that he may have had, any type of pericardial or other myocardial abnormalities. You mentioned two things, and I know when you get to your exam, Jeremy, you'll have more input on this, but you mentioned that he had difficulty speaking and ambulating. I gathered that was secondary to dyspnea, but we'll have to notice, does he have new neuromuscular findings that could suggest a underlying neuromuscular disease? And then thinking of other, right? Severe anemia, we should never rule out. And it'd be really interesting to know just any prior exposures he's had, both occupational as well as any medications that may have been introduced in the last few weeks. I think understanding also any other comorbidities, as I mentioned, medication, social history will be extremely helpful as we further our differential and think about initial diagnostics for the patient. So, Jeremy, would love to hear a little bit more if you don't mind sharing with us.
Yeah, of course. Important to add is his history of left adenoid cystic carcinoma of the left parotid gland, which was status post radical neck dissection, parotidectomy with dissection flap, radiation, and chemotherapy, which he completed 1 month ago. He initially presented with left facial nerve palsy, which is how his parotid tumor was eventually found after a CT neck was completed. Other past medical history includes some hypertension, hyperlipidemia, aortic and mitral valve regurgitation, and a PFO. He has a 10-pack-year smoking history, but quit over 50 years ago. His home medications include Symbicort, otherwise known as budesonide formoterol, amlodipine 5 milligrams, losartan hydrochlorothiazide combination medication, rosuvastatin, and 4 tablets of potassium chloride every day.
Great. Thanks, Jeremy. We're getting a little bit more information and we can keep honing our differential and things that we're considering. I just do a talk with the interns about clinical reasoning and feel like there are a lot of different ways to think through a problem. And probably no one uses just one of illness scripts or diagnostic schemas, but we always want to see what is changing about our patient and what about our information and how that informs the great initial differential that we have from Christina. And then I also like to take a very pathophysiologic approach if we can, because I think then you're building from the ground up, inductive reasoning as opposed to deductive reasoning. So from this history, I take a couple things that I'm considering that changes some of the pretest probabilities. So first of all, he had a cancer recently. I also always talk to everyone about how it's fine to admit what you don't know. I know nothing about left adenoid cystic carcinomas of the parotid gland, but I might read or ask somebody to tell me about it if they have anything like predilection to the lungs or if they metastasize at all, things that might be informative for a patient who has it. I do know that if you had radiation and chemotherapy to the head and neck area, that you could have post-radiation changes in the head and neck. And so I start thinking about upper airway syndromes that could be causing this. I know if he was on recent chemotherapy, he could be more immunosuppressed. And so I start thinking about some atypical infectious etiologies that could be causing progressive cough and dyspnea. We talked about his smoking history and that he looks like he's on a combination inhaled corticosteroid and long-acting beta agonist. So does he have some prior airways history and could this just be reflective of that? And then you also mentioned that he had some valvular abnormalities and a PFO. And so thinking from a pathophysiologic standpoint, he reported at home that he was hypoxemic and he tried some oxygen and his oxygenation really didn't get better. And so then I'm thinking about my causes of hypoxemia. Could he have some shunt or got a little better, but not a lot? And if I'm thinking about shunt in someone who has a PFO, do they for some reason now have elevated right-sided pressures where they're having shunting through them? They, of course, could also just have functional shunting because of some issue within their lungs. And so these things have changed a little bit based on the information that we have. But we're obviously going to need to get some more. And this is the type of patient I want to know how they're doing. I want to confirm on their vitals that they are hypoxemic and see what happens if we walk them and how their oxygen changes, or if we add oxygen and do a physical exam. Jeremy, can you share some of that information?
Yeah, of course. His vitals included a temperature of 98 degrees Fahrenheit, heart rate of 101 beats per minute, a blood pressure of 135/99, respiratory rate of 19, and oxygen saturation of 80% on 4 liters nasal cannula. It's improved to 97% after placement on high flow nasal cannula of 40 liters and 60% FiO2. In terms of some pertinent positives and negatives on his physical exam, he was chronically ill appearing but alert and oriented. You could notice a left-sided facial droop. From a cardiovascular standpoint, he had a normal rate and regular rhythm without murmurs. From a pulmonary standpoint, he had clear vesicular breath sounds in all lung fields without wheeze, as well as some accessory muscle use. His abdomen was soft. He had no lower extremity edema, and there was no obvious muscular weakness. Initial chest x-ray was notable for some mild bilateral interstitial edema without evidence of a consolidation or pneumothorax. A chest CT with IV contrast timed for a PE study was significant for bilateral nodules, mild atelectasis, and no evidence of pulmonary embolism.
Thanks, Jeremy, for sharing the exam findings and some of the initial diagnostic workup that you had. So, just thinking about things, I know we'll get to labs soon, but as a preliminary thinking about this, his degree of hypoxia seems out of proportion to his imaging findings, and I think may raise the question of potential shunt, as Firth mentioned. Shari, I'm wondering if you can share with us just how you teach your trainees to think about hypoxia in the ICU. So, similar with this patient was presenting to them, how would you have them frame him?
Yeah, thanks so much. So, in the ICU, I break down hypoxia in two ways. The first way that I think about hypoxia is actually from hypoxemia, which is really the majority of hypoxia. And hypoxemia is just not enough oxygen getting to the blood. And I remember those 5 causes of hypoxia that we all learned in your first aid book. And I like to get the easiest out of the way first. So that's just low FiO2. And while normally when you had the first aid book, they had a person on top of the mountain, it's a little different in the ICU or in the hospital in general, right? Because someone could be unhooked from oxygen. That's a common cause in the ICU. The other thing that I have sometimes rushed in and saved the day is if someone's newly put on a ventilator and there's a leak in the ventilator and PEEP is somehow being lost in that circuit, and so, any sort of leak within a oxygen delivery system is when I think about low FiO2. And you always look great if you go in for a rapid response and you realize the patient just pulled the oxygen out of the wall. So, quick fix there. The second one, I think about alveolar hypoventilation, and we can think of this as the oxygen just not getting to the alveolus. And in the most reasonable way, this could be someone with a hypoventilatory problem. So that could be a neuromuscular weakness. We know this guy has this left nerve injury. This could also be kind of ALS patient or someone who maybe his cancer pain, he's taking some more opioids. And so he has depressed respiratory drive for that. Other things that can cause it are COPD and asthma, where there's obstruction that keeps the actual air from getting to the lower airways. But in this type of alveolar hypoventilation, this is always preceded by hypercapnia. And so that's your kind of clue there. In both 1 and 2, this either low FiO2 or alveolar hypoventilation, there's actually no problem in the oxygen diffusing from the alveolus to the blood. In these cases, they all have normal AA gradients. The next causes, 3 through 5, are all problems with the lung from the alveolus kind of getting across that membrane into the blood. And the first one that I think of here is diffusion limitation. And these are things that cause kind of expansion within that. And pulmonary fibrosis and pulmonary edema are generally the things that fit in this category. And the one thing that I think is diagnostically or the best way to think about it on physical exam are these are people that are really responsive to heart rate fluctuations. So you can think about your ILD patient that's sitting in their bed, not having any problems, but the second they try to walk to the bathroom, they completely become hypoxic. And if you remember that diffusion association curve across pulmonary vasculature, you remember that oxygen goes across in the middle of that. If you thicken that membrane, that kind of pushes at the end, you increase transit time, and these people become hypoxic. So, diffusion limitation, remember, heart rate really causes worsening hypoxia. And then I actually put my 4 and 5s together because VQ matching and shunting are the same thing. Shunting is just the most extreme cause of VQ mismatching. And so I think of them as a continuum together. Basically, the shunt is when a Q equals 0. And I always kid on rounds. I think Jeremy's probably heard me say this. In residency, I learned that all the answers to cardiology were preload and afterload. I would say all the answers to pulmonology are VQ matching and shunting. And really, that's to say that the most common reason for anyone being hypoxic is going to be VQ matching, and the ability to match that is what makes the lung a smart organ. So it could just be simple pulmonary edema or pneumonia where the lung has a alveolar filling process, but blood is still going there, and so that's wasted space. It could be something from a pulmonary vascular disease where there's hypertrophied arterioles or there's some kind of pulmonary vasodilator on board that's causing inappropriate blood to be delivered to a not appropriate part of the lung. But when we think about that, we can think about shunts being 100% of that. That would be something that would be a cardiac shunt like an ASD or a VSD, or a pulmonary shunt like an AVM or something like that. Those are the ways I think about hypoxemia. But then I have to come to the next cause of hypoxia, and that's actually when the oxygen makes it to the blood, but now it has to go around to the tissues. And I break this down for the first way where the oxygen is carried in the blood. So there could be actually some problem with the oxygen being carried in the blood. The obvious one would be not enough blood. So someone who's anemic. I had a patient once that came in who was hypoxic because they had blood loss from lice infestation. We had other things that could cause problems with actually oxygen binding to the blood, which would be someone maybe with a physiologic problem like sickle cell in a crisis, or someone with something that's disrupting the oxygen carrying capacity. So that would be carbon monoxide or methemoglobinemia. And then the last thing I think about is the blood actually making it around the body. And that would be a shock state. We could think about cardiogenic shock, heart rate and cardiac output going into that. But that could also be a local thing, like a regional tourniquet causing problems there. But in the ICU, the other thing that one would need to think about is compartment syndrome or something like that, that would cause a regional ischemia of hypoxia. And that's how I break that down.
That was amazing. Before we even keep going, I don't want to blow past the anemia due to massive lice infestation. We would have to have you back on the show to hear about that case. That sounds interesting. I love that you broke it down like that. I really think that we don't spend enough time in the ICU talking about why we care about hypoxemia and hypoxia. And what we're really getting to is the delivery of oxygen and the ratio of DO2 to the consumption of oxygen of VO2. And so breaking it down like you did, I feel like it's a great reminder to us is that's what we really care about is tissue delivery of oxygen. And we can be doing better about that in general in medicine to be talking about it more. I have note in our ABGs at the hospital, we just started automatically getting carbon monoxide and methemoglobin levels on our gases, which we didn't get a month ago. We changed medical record system. It threw everyone for a loop. Nobody knew what to do with these values. And it was a very interesting sort of clinical change.
Yeah, I didn't really get into the toxidromes of carbon monoxide and methemoglobinemia, but I think pearls to remember are when you have a patient with a SpO2 and an SaO2 that are not correlating. That is a real telltale sign of a methemoglobinemia. And often, big clue is the oxygen saturation is around 85%. I think if you notice those things, the best thing to do is to go back to the medical record and to look to see what kind of drugs they're on. The biggest offenders tend to be lidocaine toxicity and dapsone, which a lot of people are now on for immunomodulation. Even just topical dapsone for acne usage can cause a small degree or a reasonable degree of methemoglobinemia. So it's important to remember.
Yeah, that's a great pearl. That's awesome. Great. We have a good framework or thinking about this patient. And I'm curious, Jeremy, what you guys did next in the diagnostic evaluation after that initial exam and imaging.
Yeah, definitely. So on labs, he had a BMP that was notable for an elevated BUN to 39 and an anion gap that was only slightly elevated to 17. AST and ALT were elevated to 98 and 59 respectively, with an elevated ALP of 247. He initially had a high sensitivity troponin peak to 315, but this quickly downtrended. BNP was normal at 46. On CBC, he had no leukocytosis with about 6,000 white blood cells, an H&H of 12 and 36, and a platelet count of 143. On a venous blood gas, he had a pH of 7.41, PCO2 of 52, bicarbonate of 33, base excess of 7, and a lactate of 2.6. And on transthoracic echocardiography, there was normal LV and RV function without any chamber dilation. There was mild to moderate valvular regurgitation at all valve sites with evidence of mild pH. And most importantly, he underwent a bubble study, which was positive for the early appearance of bubbles in the right heart chambers, consistent with an intracardiac shunt.
Thank you so much. So Sherry, we have this information now that we're adding onto the diagnostic framework that Christina, myself, and you have laid out. So can you comment on how these labs and echo update your thinking about this patient and what you would think needs to be done next?
Yeah, I think the first thing to say about the labs is they seem remarkably normal in a lot of ways, given the way that the patient is presenting. Part of what is noticeable about them is the patient has a small troponin leak that was pretty consistent. So, ongoing, some sort of ongoing ischemia within the cardiac, the myocytes, but not in an end STEMI kind of way, not a full thickness issue. The other things that are notable on the labs include an AST 2 times ALT and a minorly elevated ALK phos. I remember in medical school always learning that AST 2 times ALT was specific for alcohol, but I think that's a myopic view because there are other things that can cause AST. Whenever I see an AST elevation over ALT, I think, is the AST all coming from the liver itself? So you could think about other causes of AST elevation, including skeletal muscle or cardiac. That could be a cause here. But the other thing that could cause an AST over ALT elevation, this actually is congestive hepatopathy. And I think that needs to be on your differential when thinking about the echo a little bit more as well. He also has an elevated ALK phos, which could be either related to the AST elevation or be given his liver, excuse me, given his cancer could be related to bone. So maybe helpful to draw a GGT here. The other things on the ABG are the remarkable normal CO2 level in the patient. So slightly elevated, but not to the point where I think that is the reason for his hypoventilation excuse me, I don't think that is the reason for his hypoxia. And it does not seem like he has overwhelming obstructive lung disease. We kept on bringing that up with his past smoking history, but that seems to be less contributory here.
Thank you so much for going through that. And then I'll just add one thing with the echo and the bubble study is we have this patient has hypoxemia. We're seeing some bubbles. And so they're early because it's saying consistent with a cardiac shunt. If they were later, we've had our episode on hepatopulmonary syndrome. So we remember that late, we think more about intrapulmonary shunting. But it's really important to know and ask the tech or the people who are there performed it how the test was performed and when the bubbles came across. Because it could be that right to left shunting is the answer to your question, right? The patient has right to left shunting, is hypoxemic, but they will sometimes comment like, oh, no shunting at rest. And then when the patient valsalvas or the patient is coughing or the patient changes positions, then we're getting a little bit of bubbles that come across. And then two, you can try to ask them or take a look yourself and could get a sense, is this a couple bubbles or is this a steady stream of consistent bubbles the whole time that they're injecting them there? Because it's always an interesting finding when you have maybe an intracardiac shunt, but overall preserved RV function or mild pulmonary hypertension on the echo, because you're trying to figure out why and how that's coming across. A very interesting finding.
Yeah, perfect. I love that point too, right? And when I'm in the ICU, and I really like the house staff to be in the room when the echo tech's performing it, so they can definitely help quantify exactly what you were mentioning. Great thoughts to think about. And thank you, Sherry, for thank you for just helping us develop our differential a little bit more. I feel like this patient's had a lot of testing, but I still feel like we don't have a definite answer yet. So, Jeremy, I'm sure you did some more things. So, wondering if you could just share the next steps in the patient's clinical care.
So yeah, at this time we were pretty confused and stumped because this patient had really severe hypoxemia and his vitals were again, fairly normal in exception to the hypoxemia. His labs were just mildly abnormal without pointing to an exact reason as to why he was presenting the way he was. His imaging, most notably the parenchyma, were pretty clear. There were a few nodules, but nothing that kind of stood out, pointing to the exact reason as to why he was so hypoxemic. So the idea was passed around that maybe we should right heart cath this patient and get some numbers and try to figure out if there's something we're missing.
Thanks, Jeremy. Yeah, as someone who does pulmonary vascular disease, we get these cases from time to time of hypoxemia, and we just really can't figure out why it's happening. You've done like the whole workup of all the sort of causes that Shari mentioned, and we're still a little stumped. And so then there often comes the idea of like, yeah, maybe we should do a cath. And I think the important thing there is what are you looking for on your cath? Because you have an echo where the RV looks pretty normal. Now, obviously, cath is the definitive test for pulmonary hypertension, but it's probably unlikely that we're going to find severe PH in a patient whose echo looked like the way this patient did. And we have to just have a sense of what are the questions going into the cath. Not because when I ask this, like if I'm on the pulmonary hypertension service, not because I don't want to do it. I love doing a cath, but because we can do different things in the cath lab to try to get our diagnosis. Shari, have you had other cases like this, or for this specific case where you're like the hypoxemia is really vexing everybody? And what kind of things would you think about performing when we look at the pulmonary vascular disease?
Yeah, I think that is everything that was said is so true. I think this was one of the times where you have a patient with profound hypoxia and you have the pulmonologist saying it's not the lung parenchyma. You have the cardiologist saying it's not the shunt. And so maybe it's somewhere between the two. So I think that's when we said, look, we'd really like to quantify the shunt, maybe do some kind of provoking maneuvers to see if we can understand how bad the shunt run is. And given that, while we do the shunt, wouldn't it be nice to understand this pulmonary vascular issue that he's having? Because he does have elevated right-sided pressures, but his LA is normal. There's no signs of right heart failure. There's no hypertrophy on the right side. So we are all just left, I don't know, that Spider-Man meme where everyone's like pointing at each other, like who is at fault here? So I think that going to a next diagnostic test was helpful.
Yeah, that's great. And then to lay it out, when we do a shunt run in the cath lab, we really have to know in advance that this is what we're looking for because we will screen for a shunt by taking at least an RA sat and a pulmonary artery sat to see if there's a step up between them. But if we're worried about shunting, that's really for if someone has a left to right shunt. If we're really worried about right to left shunting, you really have to get a whole bunch of sats all along the SBC, the RA, the IVC. Then we use those average out and determine what a mixed venous sat is. And then really importantly, we have to get a good sense of what a pulmonary vein sat is. And so we will often do a pulmonary capillary wedge sat as a correlation to that. Some of the structural cardiologists will actually go across the atrial septum or through PFO and actually go get a pulmonary vein sat. And then one thing that Shari raises is if we're concerned there's a pulmonary vascular issue and we really don't know what's going on or driving it, the parenchyma looks normal and there's nothing else that we've thought about, and we have a patient who has cancer, sometimes when we're going to get that pulmonary wedge sat or that vein sat, we can actually draw a little blood from that circulation and send it for further testing or even cytology testing and see if there's evidence of tumor cells there. So really, but none of that I would think to do if I was in the cath lab, never thought about the patient before, and I'm just running numbers. So it's great to sort of prep things. So Jeremy, sounds like you had a lot of those conversations and maybe you can tell us what the cath ended up showing.
Yeah. So by this time, his care had been escalated due to some significant hypoxia that was just not getting better. And he was actually admitted to the ICU under the care of Shari, myself, and the medical resident team. And yes, he eventually did undergo a right heart cath, which was notable for normal biventricular filling pressures, a mean pulmonary artery pressure of 19 with an elevated PVR of 4.75 Wood units, normal cardiac output and index, which was 4.17 and 2.65 by Fick, and 1.96 and 1.24 by thermodilution, respectively, and a small right to left shunt with a QP to QS ratio of 1. Most interestingly, a wedged aspirate during this right heart catheterization returned positive for malignant adenocarcinoma, which was consistent with pulmonary tumor embolism.
Thanks, Jeremy. Wasn't expecting that, but as you said, this was definitely a interesting case. And for those of you who have been listening, and you may have just heard a lot of different numbers, and for me who doesn't do pulmonary vascular disease every day, we do have a how to interpret right heart cath, which we did with Steve Matai and Allison Sow. So definitely check that out. But Firth and Sherry, since you do this more day to day, I'm wondering if you can help us unpack some of this data and anything that you want listeners to take away from the results that Jeremy mentioned.
Yeah, I think the one thing to do is to pause, right? Because when you get sensitology, you don't get that immediately. So the patient returns to our ICU and we have these right heart cath numbers and we're going over them. And at first, when you first look at the numbers, you have a mildly elevated mean arterial pressure, 19. That's not normal, but it's not to the point where anyone would say, oh, this person clearly has pulmonary hypertension. But I think what is remarkable is that despite having a low cardiac output, so his by thermodilation, his cardiac output's pretty low, his Wood's unit is very high, meaning despite having low flow through something, the resistance is extremely high. So we could imagine if the patient had a very high cardiac output, this would be even higher. And I think that is the part that really, when he came back to the ICU, that we were most impressed by is the elevation of the pulmonary vascular resistance more than his mean arterial pressure or the cardiogenic component of this. And from there, we were truthfully, the patient was decompensating rather quickly. And we went to the family and were comfortable enough to say, we really think that there's a process happening in the pulmonary vascular system at that point that's causing this elevation of this resistance. And it's increasing so quickly that we are most concerned about cancer. And so I think at that point, our pretest probability had changed to almost 100% of this being a tumor embolism syndrome. And I think that's how we got to the diagnosis. We were very thankful to give the family closure and actually get the cytology before the patient passed away. But we were candid with the family and said that possible this will be negative, and we still think it will be cancer.
Thank you, Shari. Yeah, this is a great, we're going to post these numbers. This is a great tutorial on looking at cap numbers because you have to have a systematic way, as you were saying, of looking at them, or you can miss it because the mean PA pressure is 19 on this one. And you might be like, oh, that's under the 20 that they say is normal, but still not a normal value. But I'll add to even your great point about the PVR is that I start by actually looking at filling pressures because my filling pressures then help give me a context. And in this case, the wedge is 0, the RA pressure is 1. Now, let's take into account that probably the wedge is not actually 0, but of course, as a cath lab, we know we're getting close to that. I presume that this guy who was super hypoxemic and sitting on the floor in the ICU was dry lungs, happy lungs, getting diuresed aggressively, just like any of us would have done, and was super dry and still had this high PVR and had this transpulmonary gradient of about 19, which is very elevated. And so in addition to if his flow was higher, if his volume was higher, I bet you his PA pressures would have hopped out more. And so you always have to approach your cath in that diagnostic or systematic way. And it's so interesting that you guys brought this case. I had a case very similar to this recently in the ICU where it was actually, I was consultant in ICU where a patient had the same sort of severe hypoxemia out of nowhere, new evidence of pulmonary hypertension. And then the question even became, should we start pulmonary vasodilators? And we even tried just as sort of a Hail Mary, but predictably now knowing in retrospect what the patient had, the hypoxemia just got so much worse because this is just a pure anatomic shunt from small circulation issues from the tumor. And we actually raised the same thing. We said, we think this is tumor microembolism syndrome. And on autopsy later, it came back positive, which at least is some closure that the diagnosis was accurate at the case, although obviously an unfortunate outcome.
I also want to make one more point because we have a great working relationship with our allergy colleagues, and we were talking about the possibility of maybe even empirically closing the shunt, even though it was small. But if you think about what would actually happen there, that would actually worsen the patient as well. So I think it's really important to have all the data before you do these other interventions. I think pulmonary vasodilators, closing shunts, even though might not be specific, are things we can think about. But I think you also have to go back to numbers and make sure they still physiologically will make sense.
Yeah, those were such great points to think about, and just love share that definitely a multidisciplinary discussion was needed for this patient, and kind of love that, as you said, love the collaboration between the heart and lungs and maybe something in between. So that was a good way to frame it. And I just wanted to go back to you, Jeremy. I know that this diagnosis of pulmonary tumor embolism, or PTE, was identified based on the aspirate that was obtained. And I know as this case, as we all are learning a lot about it, I know that you probably delved into it a little bit more, and hoping that you can teach those listening today and share some high yield points with listeners.
Yeah, Christina, I'd love to. So yeah, pulmonary tumor embolism, which is sometimes also referred to as pulmonary tumor thrombotic microangiopathy, depending on the context, occurs when malignant cells within the bloodstream become lodged in the lumen of the pulmonary vasculature. The true incidence of this complication is difficult to assess, but has been reported between 2 and 26% based on post-mortem examinations. At post-mortem, the most frequent solid tumors found are usually adenocarcinomas, with the most common types including breast, gastric, renal cell, prostate, and hepatocellular. Most cases of pulmonary tumor embolism are diagnosed post-mortem on autopsy. The antemortem diagnosis of PTE is definitely more challenging, with only a few cases described in the literature discovered via lung biopsy or, less invasively, a wedged pulmonary artery aspirate. This technique has a sensitivity of about 80 to 88% and a specificity of 82 to 94%. Unfortunately, finding evidence on chest X-ray or CT scan alone is challenging. Although there is no definitive therapy for pulmonary tumor embolism, supportive therapies like treatment with oxygen or even mechanical ventilation if needed, pulmonary vasodilators, diuretics, glucocorticoids, and anticoagulants can be given. I'll try that again. An attempt at tumor burden reduction can be made as well with chemotherapy, radiation, or surgical resection. However, in many cases, this diagnosis is unfortunately a fatal one.
Sherry, any other teaching points that you have that you want to share?
No, I think this is one of the cases, or this is highlights a case where it takes a while to get to the diagnosis, but understanding and how you started the framework of does this problem make sense with everything that I see gets us to the eventual diagnosis. And I think the other thing to do is to not allow premature closure to happen. So I think people could have stopped and said, oh, there's a shunt and that's what's causing this.
Mhm.
But I think when, despite having a diagnosis that might present like that, has different severity, you need to really make sure you're not missing something else.
Totally. And I know that you both said that you were both deeply involved in the case when this patient was admitted. And just wondering for those listening today, if you could just tell us what happened with the patient and how things ended.
As I stated before, this disease is sadly fatal in most cases. In our patient, after worsening oxygen requirements and a non-improving mental status, the family opted to proceed with palliative extubation, and the patient passed shortly thereafter.
I do think we were able to give the patient and their family a lot of closure by giving them the presumptive diagnosis prior to removing the ventilator and ultimately giving them the diagnosis with the pathology that returned.
That's exactly right. And I think thinking of this case and having the higher likelihood of doing the wedge aspirate, I think maybe have, as you said, change that overall diagnosis and outcome that you were able to share with the patient and the family. Furf and I really want to thank you both for coming on today and sharing this, and really just walking through the steps and helping us reason through this case and really learn a lot from it. And we're both so excited to continue building this network with NYU. And before we wrap up today, would love for each of you to highlight what it's like to practice and learn at NYU and what you value about the fellowship training there. Jeremy, I'll go ahead and start with you.
Yeah, definitely. I'm incredibly lucky to have matched here at NYU. It's been a phenomenal place to learn and grow the past year with a fantastic group of faculty and co-fellows who all care deeply about patients and, of course, evidence-based medicine. And I'm grateful to have so many amazing mentors, such as my program director, Dr. Jizzle Harris, and Shari, my APD, whom I was fortunate enough to work and learn from on this interesting case, and will be doing my research project with in my final year. So looking forward to some future fun adventures together.
Yeah, I love NYU. I came here as a fellow and they haven't gotten to kick me out yet. I think part of it is the diversity in the training areas that you get here. You are at Bellevue, you're at NYU, you're at Brooklyn Langone. And so you're at a lot of different types of places. And thus, I think you get a true preparation to be a rock star as an attending anywhere in any setting, outpatient pulmonary, inpatient ICU. You really become a clinical expert at anything, and you can decide what you want from life and what you want your future career to look based on the diversity of those training experiences. I also think that we have a lot of people that are just uh, good and nice people. And if you're working with nice people and good people, it's so much easier and better. And coming in with people that really know that we're there for a big purpose to take care of patients. So I really love working here and I love being part of it. And please, everyone, send your applications. We're ready to review. We're doing in-person interviews this year
Oh,
at NYU. Yeah.
wow. The switch. Is that everybody?
Only
So, yeah.
20% of programs are doing in person this year, I think, is what
Yeah,
Green said. So we
interesting.
are we're bucking the trend and we want everyone to come and see what we have to offer because we think it's awesome.
That's awesome. Great. Who wouldn't want to come to New York City for a day? It's the best. Thank you so much for coming on the show today. We like to wrap up with a takeaway point, just to leave people with something lingering as they are arriving and finishing their commute wherever they are. Mine is that it's really important to know when you're doing a cath beforehand why you're doing it so that you can prepare appropriately to get the right information. And then when you're reading a cath, to do it systematically. We talked about this in a prior episode with Alison Sow and Steve Bataille back in actually April 2022. Crazy, Christina, that it was that long ago. But you can listen to that if you want to hear our approach. But having that systematic approach will help you decipher some of these really tricky results when they come in and they can appear deceptively normal. Christina, what about yourself?
Yeah, I had one of the great points I think Sherry started off with, because I think when you're in the ICU and you're thinking about hypoxia, I think so many people dismiss like the low FiO2, right? Because everyone's like, we're not on a mountain. Like, why are we even talking about this? But really just thinking, right, is there a break in the circuit or is something unplugged? So that has really stuck with me and something that I think I'll start to train my learners about and make sure I make that point noted. So I love that.
That's great. Sherry, takeaway point?
Yeah, I think we often think of circulating blood as everywhere and we think that systemic is systemic. But I think what this really highlights is the idea that blood can still have microcirculation and that a pulmonary artery aspirate is helpful at looking at the microcirculation that's occurring in the lung area.
Definitely. And Jeremy, we'll wrap up with you.
Yeah, just before I say my takeaway point, I just want to say thanks so much for having us today. I'm again a big fan of the show. It's definitely very exciting for me. But yeah, my takeaway point is to remember that not all lactic acidosis is from poor perfusion, and to think through type A, type B, and type D causes when evaluating patients, just like our patient today.
That's awesome. Thank you guys again. And thank you all for listening. Make sure you subscribe and like us and rate us wherever you're listening to this podcast, and tune in 2 weeks for our next episode. This episode was written, produced, edited by myself and Christina Montemayor. The music's original music by Eric Rogers, and we'll see you next time.